This is a brief disclaimer that while I am a licensed physician, the contents of this podcast does not establish a patient-physician relationship, and nothing in this podcast replaces personalized medical advice from your medical professional. Hello, and welcome back to the Long COVID MD podcast. I'm your host, Dr. Zeest Khan. I'm a board-certified physician who worked for over 10 years saving the lives of my patients. But since 2020, I've been battling the symptoms of long COVID and am working full-time trying to save my own. In many ways, I've had to be my own doctor the past 3 years, and my experience in medicine has certainly guided my steps toward recovery. In this podcast, I'm opening up about my journey with long COVID and explaining how I, as a physician, am navigating life as a patient. Send me your questions and comments. I want to hear from you. Email me at longcovidmd@gmail.com and find me on Twitter as Dr_Zeest. Today's episode is a big one. I've spent a lot of time the past 3 years thinking about it, actually, and I hope it comes across clearly. I also hope it's helpful to you. Today I want to share the skills I practiced in my medical career that have been most helpful in my recovery. In essence, I want to share the ways I have acted as my own doctor. Now, I'm not talking about anatomy and science, and to be clear, this is not a guide to medications and therapies. I am not endorsing the notion that you medicate yourself covertly. I am not giving specific medical advice. I want you to partner with a medical professional for that. What I will share are the 5 principles I used as a doctor to ensure the safety of my critically ill patients, and how I applied these principles to myself when I became a patient. Since falling ill, and especially at the times I felt the most powerless, I leaned on these techniques to make sense of my symptoms and to make really important medical decisions. Sometimes, by going through the principles, I actually reassured myself that I was doing all the right things and I had to just keep going. These principles explain the methods, techniques, and even the emotional skills I cultivated as a physician working in life and death situations. They are simple, but they are not always easy. So, as with anything, take from them what serves you and leave the rest. To explain these 5 principles, I'm going to tell you about my typical workday as a doctor. I'm an anesthesiologist who specializes in the care of patients having heart and lung surgery. Like many of us with long COVID, my patients had serious and complicated diseases. Very few could say that their only problem was heart disease, because they often had lung disease like emphysema, neurological disease like stroke or Parkinson's or chronic pain. They had diabetes, arthritis, cancer, and blood disorders. Each patient had a combination of symptoms and a particular set of disease processes. Some could function very well, but others were debilitated. Just like us with long COVID, though, regardless of how they appeared, regardless of how well they could function, they all had serious, complex disease. Looks are deceiving, and I know that at an anatomical level. Heart surgery is not a small deal. It is a profoundly invasive treatment, and a lot goes into the preparation. both for the patient and for the hospital. It requires an amazing amount of vigilance and care to get a patient through surgery, through recovery, and by the time a person gets discharged home, literally dozens and dozens of hands have been involved in their care. It's a team effort for sure, and there is very little room for error. My role as your anesthesiologist was to ensure your safety and comfort. That's my elevator pitch to every patient I have, whether they're getting a lung transplant or if they're getting a skin tag removed. My job, I would say, is to make sure you're safe and comfortable through the surgery. What I mean is that I keep you asleep and alive through the surgery. And for heart disease, this is particularly complicated. Anesthesia itself can be dangerous, but when you have heart and lung disease, it's especially dangerous, so I have to be very careful about administering it. Heart surgery requires a lot of invasive monitors, and I insert many of these special monitors in your body myself. I administer drugs through IVs and breathing tubes. I keep your blood pressure in the right zone to make sure that your heart doesn't stop and that you don't have a stroke. I also drive a special camera and take live images of your heart during the surgery. I give fluids, blood transfusions, I manage machines, I draw lab work. I do a lot during the hours it takes to perform surgery. I've taken care of patients during surgeries that last 12 hours or more, and I'm often involved in their care in the ICU before or after surgery when they're unstable and fighting to survive. I participated in my first heart surgery in 2008. So I've been doing this for a long time. At least I did before I was disabled by long COVID. So that's my background. These are my qualifications for proposing my 5 principles. The first principle is not as tangible as it is philosophical, but it's also foundational. And it is this. This work, this situation, this condition is both critical and dynamic. Our work is critical and dynamic. Critical means this is serious. It's life-altering. It's important. Now, it's easy to identify a critical condition when a person has been in a car accident and is unconscious. Even if you don't have any medical training, you can recognize that critical condition. It's easier for me to identify a critical condition when it's less obvious. Say I review the medical tests of a person with severe heart failure. Even if they're in front of me, dressed really well, with their hair done, and the person's family member says, she's fine. She gets winded sometimes when she walks, and she definitely walks slow, but look at her, she's okay. Because I have an added level of expertise in identifying heart disease, I can go, that's not true. You're not fooling me. You're actually in danger. My eyes have been trained to see it. With long COVID, unfortunately, we are suffering from a critical condition that is sometimes recognizable to the general public and sometimes not. Sometimes it is not recognizable to even medical professionals. But the reality is, long COVID demolishes a patient. Long COVID is a life-threatening disease that limits our ability to engage in life in the most basic ways. If untreated, and sometimes even despite treatment, we are left bedbound, immobile, silent, and in pain. Take it from me. I have seen a lot of horrible things. I have witnessed a lot of suffering. I am someone who knows firsthand what the word serious means, and I can tell you long COVID is a serious condition. The next part of the first principle is that this is a dynamic situation. It's constantly changing. And the situation will continue to change. This is a given. It's a truth that cannot be modified. It is actually a fundamental tenet of medicine, especially in high acuity care. I'll illustrate this with a simple example. So my hospital workday would start either at the crack of dawn or before the crack of dawn, and it would end at some point later. At the end of the day, I would review the surgery scheduled for the next day so that I could be prepared. Sometimes I talked to the surgeons to clarify the specifics of what they were planning. I would definitely review the medical chart of the first person scheduled, and I would do this routine at the end of every workday. But I would know that the next morning, the schedule might be completely different. Now, this isn't just an inconvenience to one person. This affects the entire hospital. Changing the schedule is not a small deal because we need particular tools for each surgery. Those tools need to be working and sterilized. That takes time. We need appropriate staff in the hospital. We need ICU capabilities, sometimes very specific ones. We need specific blood available. So the whole hospital is affected by changes, and it has to respond to those changes. On a more personal scale, I'll describe this dynamic situation in the operating room. So the events during surgery are in constant flux. Caring for a patient in surgery requires constant vigilance. This is true for the ICU, often for the emergency room too. And that's stressful. It's stressful to work in an ever-changing environment. We call it a dynamic condition. You could also use the word instability. It's not an efficient way to run a system. It's not efficient to have to deal with changes and deal with them rapidly. But it is reality. The hospital system has to accommodate uncertainty, and it works best when the system and the teams within it can pivot quickly and effectively. In surgery, we are always pivoting. That's part of the reason that the job is hard to do. Being comfortable with uncertainty is not easy, but it's a skill that can be cultivated. It's a skill I learned during training and continued to develop during my career. You can talk to anyone in healthcare, especially surgery, ER, ICU. This is a skill that we all train, and it's a skill that is essential. You might have experience dealing with constant change, depending on what your career was or your experiences in life was. But a lot of us are not used to pivoting rapidly. And I want to remind you that this is, or just acknowledge just how stressful this is. And it's not something you should assume that you're comfortable with or punish yourself for not being comfortable with or having difficulty doing. We have a dynamic disability with long COVID. How many times have you gone to bed feeling one way and making plans for the next day, even if they're small ones? And you wake up and you look down and you're like, hello, who are you? To your body. You can't recognize it. It is functioning its own way, and it's telling you it has specific needs that are really different, specific needs and specific capabilities that might be really different than just a few hours ago. This is part of the system that we're working in. This is part of our condition, just like this was part of the reality of working in a hospital. Even though it's frustrating, we have to accept it. So principle number 1, this is a critical and a dynamic situation. Principle 2, complex problems can be broken down into smaller parts. Before bringing a patient to surgery, of course, I need to know their medical history. I want to know as much about them as possible. The human body is a lot to take in, so in medical training, we learn to understand the body as a set of systems. It's not a perfect method because we are more than the sum of our parts, but it can help paint a comprehensive picture. The system we use in medicine is organ systems, and I invite you to use this method with your own symptoms. When you do this exercise on yourself, you have an opportunity to thoroughly reflect on your symptoms, to localize them, and possibly categorize them. This might clarify your symptoms as you spend time describing them, and it's also going to empower you to communicate with your medical care team, because these are the questions that doctors are going to ask you. What is your symptom? Where is your symptom? What makes it better? What makes it worse? Now, I want to be clear that it is not your obligation to be a quote-unquote good patient. It's really the doctor's job to investigate your symptoms and work them up. But it is a big undertaking for us as patients to schedule and get through a medical visit. Medical visits are getting shorter and shorter because of outside pressures, and I want to make it as efficient for you as possible. So doing this exercise is going to help you understand your symptoms better, and it will help you communicate your symptoms better. Assessing a patient by symptoms is like doing a body scan. You can do it for yourself by grabbing a piece of paper. If you're a list maker, you can make a list of each body system. If you prefer pictures, draw a stick figure or a basic picture of the human body. It does not need to be complicated. Think of the board game Operation and the guy on there. Okay, so we're talking about the big picture. Start at the top and work your way down, listing any and all symptoms you have associated with each body part. It's okay if there's overlap and one symptom is listed in 2 places. It's also okay if you don't know exactly which organ system to assign a symptom to. You can just pick one and move on. List symptoms with each organ system and use a couple of adjectives describing each symptom. So start with the head. which represents the neurological system. So this is where you can list headaches, memory changes, dizziness, even generalized pain. Eyes, vision changes, nose, sinus congestion, changes in smell, ear, changes in your hearing, tinnitus, ear pain. Now move down, throat pain or difficulty swallowing, neck stiffness. We move down to the chest, which contains the heart and lungs, the cardiovascular and the respiratory systems. For your heart, list things like your heart racing, your heart pounding, or having any chest pain. This is also a good place to note if you're having any swelling in your legs, because part of the cardiovascular system is composed of cardiac, the heart, and vascular, the blood vessels. The heart's job is to pump the blood out, and the vessel's job is to bring the blood back. Oftentimes, swelling in the limbs can be caused by a problem in the cardiovascular system because the blood vessels are not able to do their job well, or there is an issue with your heart itself. It's not always the case, but it often is. Also in the chest are your lungs. So list any shortness of breath you have, wheezing, and the like. Your abdomen contains your gastrointestinal system. So list appetite changes, changes in your bowel movements, sensitivities to foods, nausea. The pelvis contains your reproductive system and also your urinary system. This is a good place to list changes in your menstrual cycle if that applies to you, changes in your generalized symptoms that track with your cycle, changes in libido, the ability to have or sustain an erection. After the pelvis, you usually move on to the musculoskeletal system, which, as the name implies, includes your muscles and bones. This is also a place that I would include hair and skin changes, although that is technically a different system. So list pain in your body, stiffness in your body. Pay attention to your joints, any pain or swelling that you might have. You have big joints, but you also have small joints like your knuckles and the places in your fingers that bend. So list those here. If there are symptoms that you can't assign to a specific organ system, make a separate list for those. You can call it additional symptoms and list all of the symptoms that you have in mind or have difficulty describing or assigning there. Because all of this information is important. All of your symptoms are part of the puzzle. After you list and describe your symptoms, which is going to take a while, you don't need to do this all in one go. The follow-up or the next step is going to be noticing what might trigger the symptom, if there is any patterns to it, what makes it better, what makes it worse. And again, remember, this is going to take some time. As you use this body scan process, you will be able to name your symptoms. They don't have to be medical words. You can use your own adjectives, you can use your own words to describe what's going on. And if you do this often enough, you might be able to identify some patterns. When does the symptom come on? What was I doing at the time? What makes it worse? What makes it better? Does it wear off over time by itself, or do I have to do something, and how long does it take? You're giving words to your body's signals by doing this, and this is really powerful information. It's going to be very helpful at doctor's visits and particularly at specialists' visits. I must say here that I know doctors are not easy to access and are often not helpful when it comes to long COVID. It's true for me too, and I'm a doctor myself. Part of that is because long COVID is a multi-organ system disease, and medicine doesn't have multi-organ system doctors in the way that we need. What doctors are used to is specializing in organ systems and treating those organs. We get really into the nitty-gritty of one body part, and so a specialist in that body part might not be able to recognize a connection to another symptom because it's part of a different body part that they haven't studied as in depth. This is not a perfect system, I know, but this is the current system. And this information is helpful, like dividing up your symptoms by organ systems can be helpful, because even though we don't know or have a treatment for the underlying pathology of long COVID, I do know that symptom management can significantly improve our function. And that's not nothing. We want cure for the underlying disease process. But while we are working on that, improving our function is really going to help us engage with life better, be more independent, and hopefully prevent us from further injury. So again, studying the human body by organ systems is not a perfect method, but that's the paradigm medicine uses right now. And I want you to know that information. I want you to know that language, because I think it will be very helpful to you during your next doctor's visit. Principle number 3, inventory your resources. As an anesthesiologist, there is no middleman between me and my patients. In my clinical practice, I met the patient, I placed or inserted monitors, I administered medications, and I managed care from start to finish. Ensuring a patient's safety is a big responsibility, and I do a lot on my own. So every morning, I would make sure I had the medications that I needed, the equipment that I needed, and the people that I needed. Because even though I do a lot on my own, I am still part of a team. There are people in the room with me, and these are part of my resources. Some of the people, like the surgeons and nurses, are with me for the entire journey. And there are other people who might come in when needed, then leave. This could be another anesthesiologist to give me extra help, either physically or help me think through a problem. It could be a member of the custodial staff replenishing supplies so we can keep going. Everyone has a specific skill set, and everyone will influence the outcome. Nobody can replace a heart surgeon who can work in an open chest, and nobody can replace an orderly who knows the shortest route from the operating room to the blood bank and back. Both of these people are vital at the specific job they do, and I can't switch them, right? Since I've had long COVID, I have thought about this idea of my resources. And I've taken inventory of my personal resources now that I'm a patient. The most basic resource I had in the hospital was my medications. The most basic resource I have now, and that most of us have, is our money. How am I going to support myself when I can't work as much as I did, or if I can't work at all? What are my plans for financial stability or survival? My resources also include my medical network. What kind of providers are available to me? What kind of medications are on formulary for me? Here in the United States, our insurance companies really limit our options. And so I needed to have a good understanding of what my healthcare coverage was and what was available to me. So those are like the basic resources, but we also have human resources, just like we did in the operating room and in surgery. And those people are very influential in our recovery. Just like in surgery, some of these people are going to be with us for the bulk of this journey, and others might come and go. You want a team that you get along with and who you work well with. But unfortunately, that's not always the case. You still need to keep your priorities straight and stay professional so that this critical, dynamic, really important job gets done and the patient's safety is ensured. Just like in surgery, as I've navigated my own long COVID recovery, I really need people who are on the same page as me. I need support. I need a team who works well together, like I said. And I have been disappointed in this arena, like I know many of you have. There were people I thought who would be with me, who couldn't show up for me. There were people who meant well, but were bringing me down, even though they had good intentions. But on the flip side, there were people who really showed up and new friends who offered support. A lot of those new friends have been online. And so now I have built a really great team who support me, and I've minimized the influence of those who bring me down. As with surgery, it's nice to have a small core group to stay on track and a lot of supporting players who can help when needed for smaller tasks. In order to access this resource, though, we need to learn how to ask for help, and that can be uncomfortable for us. But we can discuss how to do that more in the future. But it's really critical that we get comfortable asking for help. Principle 4. Textbooks are not bodies. So before the surgery starts, I have met my patient. I've learned their medical history by breaking down their issues into parts. I've checked my medication cart, my anesthesia machine. I've called the blood bank to make sure we have exactly what we need. The ICU knows we need a bed and staff for the patient after surgery. The nurses and surgeons are in the room, and I'm going to administer anesthesia. I use a combination of medications I have used hundreds of times. In fact, most patients receive the same medications to undergo anesthesia. But my care and dosing of these medications is hyper-personalized. To be a good cardiothoracic anesthesiologist, and I am and was a good cardiothoracic anesthesiologist, you need to master pharmacology. We have a lot of research that's provided the mean effective doses for all the medications I use. But no research can tell me exactly how much the human in front of me needs. Because I have assessed the patient's medical history comprehensively, and because I have experience using these drugs on actual humans in various states of health, I administer what I think is the right dose for her. And then I wait and I listen to what the patient tells me. Even if my patient is asleep, her vital signs and monitoring give me clues, communicating with me, telling me that was too much, or maybe more of this, maybe more of that. By listening to my patient, I can hyper-personalize care. More important than what dose the textbook told me to use is what the patient is showing me works. Generally, my heart surgery patients are sensitive to medications, but some need larger than typical doses or several drugs to treat one problem. My job is to listen to my patient. I say this here because I want you to listen to your body after starting a treatment. What is it telling you? Believe it when it communicates with you. Many of us with long COVID are sensitive to medications at typical doses. The hypersensitivity, it's not in your heads. We may need altered doses to be effective. We may need different doses to minimize side effects. A good doctor will listen to your feedback and help you taper your doses or titrate them. But even I have had doctors tell me that side effect's not possible at that dose. The doctor was wrong because the side effect happened. As an aside, we'll talk about medical gaslighting more in future episodes. But just remember, if they do it to me, a subspecialized doctor who administers medications professionally, don't take it personally if they do it to you. It's a big flaw in the culture of medicine. In my example, I chose to establish care with another doctor. Once the workup I needed with that one was completed, I didn't bring up the side effects again. I found somebody else to talk to about it. So keep track of how medications make you feel. This doesn't mean that you need to stop them altogether, but take note and believe your body when it sends you a signal. Remember, your body is not a textbook. It writes its own chapters. Principle 5. The first principle I mentioned, I said, was a bit philosophical, that we need to be comfortable with uncertainty, that we need to accommodate change. This last principle is also a philosophical one. But just like the first principle, this bit of advice has practical implications, and it's an important determinant of your success. So, to be a doctor caring for highly sick patients the way I did, to come to work day in and day out, seeing people suffering, hoping and working very hard to help them survive, takes a lot of emotional endurance. Without that endurance, it's easy to crumble because not all stories end happily. I have seen a lot of scary things, and I've been involved in very scary situations. And in those situations, I haven't been a bystander. I have had to focus, understand the problem, and take decisive action. I was not born knowing how to do this. I learned how. So my final principle is to cultivate resilience. I'm sorry if this sounds cliche, but it's very meaningful in my line of work, and it's been meaningful now that I'm a patient. Just as it was a fact that medical work involves uncertainty, it also involves a lot of heartache. The same is true for those of us suffering with long COVID. We have a big task in front of us with enormous implications for our lives. We are literally trying to save our lives. What's happening in our bodies is scary. It's affecting our livelihoods. It's affecting our relationships. It's upending our entire lives. Of course, it's going to affect our psyche too. Now, I want to be clear. I don't think that toxic positivity is helpful. I do not believe attitude is a cure for physical disease. But I do know that managing my mindset and calming my body is the first thing I would do when I would walk into a room of a patient in cardiac arrest. It's the first thing I do when shit hits the fan and I need to act. Doing a quick centering exercise during an emergency is really important. And early in my career, I thought that's what resiliency was. I now know it's part of it, but actually I was just being an effective first responder. I wasn't cultivating resilience. Centering yourself helps you manage your fear during an emergency, but the fear doesn't go away. Early in my career, I didn't understand this. And when you experience or witness tragic things, I realized the trauma stays with you. And you have to tend to it before you can release it. You have to tend to it so that you can release it, so that it doesn't take you over. I, like many doctors, learned to push it down and move on. Push it down and get on with the next case. Push it down and take care of the next patient. We put that fear in a box deep inside us and shut the lid. But at some point, the box gets full and the creature inside it starts poking out. It needs attention. Some of us, instead of tending to it, appease it. This can present as anger towards people who don't deserve it, isolation, sometimes substance use. Those methods can release the box, but it is at a very big cost. As I've grown, I've realized a healthier way to deal with this is to admit that the box exists and build safe places and methods to tend to that creature inside. We have to admit that we are hurting. We have to admit that we are in emotional distress as the first step to processing it. For me, just saying it aloud helps. I am sad my patient died. I worked so hard to save her. Nowadays, I would say, I'm ashamed I can't work anymore. I feel useless lying in this bed. I want to do something. I want to engage in the world. I say these things aloud, and then I've learned to respond to these statements from a place of love and compassion. So, in response to feeling sad that my patient died or a patient died, I respond by saying, I did everything I could to save her. I grieve for her and I feel sad, but I can still do my best to help others. Now, in response to the feelings of shame I have or frustration I have about being ill, I can say, I'm recovering from an illness. Lying in bed is a treatment. I'm being responsible. So even though I want to do something more fun right now, I am caring for my body in the best way I can. I want to point out that I'm not a psychiatrist, I'm not a psychologist, but these are exercises I have learned and I do regularly. The point is, navigating grief is very important. Grief is going to be a part of this process and will be a part of your recovery. Cultivating resilience may look different for you than it looks for me. You may benefit from the help of a psychiatrist or a psychologist or a therapist. Again, I'm not saying mindset will cure you. I'm saying the reality is our emotions and our psyche will take a hit by being this debilitated. Emotional resilience will strengthen your ability to recover because it will keep you in the game longer. It will help you focus on what needs to be done. For many of us, this is a long game. This is going to take a long time. And emotional resilience is going to keep us in the game. To recap, the 5 principles that I've learned working as a doctor that I have applied to my recovery are these. 1, this is a critical and dynamic disease. 2, complex problems can be understood by breaking them down into smaller parts. 3, take inventory of your resources and learn how to use them appropriately. Principle 4, textbooks are not bodies. You will respond to treatments in a unique way, and your treatment should be hyper-personalized. And lastly, cultivating emotional resilience will benefit you for this long, difficult journey. Thank you for listening to this 3rd podcast episode of Long COVID MD. Reach out to me, ask me questions, let me know what you want me to elaborate on or clarify. My email is longcovidmd@gmail.com. You can find me on Twitter at Dr_Zeist. Until next time, I hope you're doing well today, and I'll talk to you soon. Bye for now.